Welcome to our quick geriatric lecture. This is going to be a condensed version. Most of the information in here is going to be very similar or a review of stuff that we've already learned. So we're going to talk about geriatrics, and we need to define that term. That's for people that are 65 years of age or older. And as we know, that's a constantly changing population because people age every day and get over that hump. Um, but when we look at the overall numbers, and especially compared to like the 2010 census to the 2020 census, the US population count, and there's a 34% increase in those that are considered geriatric. And so that means that our old age dependency ratio is the number of older people for every 100 younger adults. So as this is increasing, we see the numbers going up, we're going to have a larger number per 100 younger adults. That's also, I'm talking about the same thing in the graying of America as that population increase, as our population ages. We're just having a continuous boost in the geriatric population because we're not reproducing or having as many kids, younger people, and it's a slowdown in that population boom, essentially. So, most of the geriatric patients that we are going to see for a really long time, or for the last couple decades, we saw a lot more geriatric patients that wanted to live independently, and didn't want to go into nursing homes. But now we're seeing a counter trend of that, where older people are they're still maintaining their independent lives, but they're finding that it's much more affordable and it's much more sociable. And with the family trends and changes in our culture, we're seeing a lot more nursing home admissions increase as as those boomers get older. Um, some of the considerations that they take into account is marital status, financial, all those things listed. And it definitely is a cultural or an ethnicity um, dependency, because if you think about it, so there's especially Asian and Hispanic cultures, they'll have multiple generations inside the home, and that's normal for them. But as they become more Americanized and more come towards the overall culture, we see a change and we see people going into these independent and more, like assisted living facilities and those kind of care environments. Let's see. There's different levels. I think you guys have all seen it. There's the senior living facilities where there's no assistance. It's completely independent. It's just like an apartment complex where all the seniors hang out. We see the assisted living where we have someone come in, check out help them with their meds, but they still have a full kitchen and they still have a full apartment. They just have a little bit of help. And then we see more of the skilled nursing facilities where they're completely dependent for all of their daily needs from the facility itself. Um, Grown children are affected a lot by the decision and of what their elderly or their geriatric family members might need. So they're considering, I think the baby boomers especially are starting to take their grown children into account. We've seen the trend overall in our culture where instead of it being a single income household where mom or dad, traditionally it was dad that worked and mom took care of the house. Well, now as we're seeing more of the transition and the economy's showing us that we need two incomes to be able to afford things, we're seeing less of the grown children being responsible for their parents' care. There's also a lot more opportunities for seniors as well. And that includes things like, and when they're in those assisted living facilities, they get delivered meals or they have a cafeteria they can go to. They have, like, if you go into some of these assisted living or independent living facilities, it's like an entire little village right in there. So it is nice, and then they'll have different steps in some of those facilities as well. So if they, decide that they need to go from independent living to assisted, it isn't such a huge transition. It isn't such a burden on those around them. And then there's a lot of psychosocial factors that are influencing aging. That feeling of uselessness or being unproductive in society tends to lower people's self-esteem. They can get more frustrated with their inability to do a lot of things as well. And there is some more depressive feelings that can come result, especially if they're mourning the loss of their ability to ride their bike, or they used to run every morning. All of those things they're no longer able to participate in. They have that kind of like mourning period as well. However, a lot of these people too, ask my mom, who turns 65 in August and is retiring the day she turns 65. She's doing that and she's really looking forward to that sense of freedom from working. They've put their time in and now they want it paid back. Another thing here is the bereavement over loss of friends or loved ones. That's something my great grandma, or my grandma, my kid's great grandma, sorry, we call her great grandma now, but my kid's grandma is, or great grandma, I can't even speak. Anyway, my grandma is 91 now, and we were just talking the other day, and she's like, I used to have 5 or 6 lunch dates a month. I had a bunch of different friends. We'd sit down for lunch and get together and blah, 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 blah. And she's like, they're all dead now. Her sisters that she was really close to. She's 91 and she was one of 13 siblings and there's only 3 of them left and not the ones that she was really close with. Those kinds of things. My grandma was like, I'm ready to die whenever, because she has her close family. She has her grown children and her grandchildren and great grandchildren, but we see her, 2 or 3 times a month, which leads her to feeling lonely a little bit more. Overall, we're going to talk about the anatomy and physiology of the geriatric patients. Overall, the process of aging really begins in your late 20s and early 30s. Believe me, in my mid to late 30s, I'm definitely feeling some of those aging signs. But overall, we really start to see that process. And it is a linear process. The rate at which a person loses function does not increase with age, meaning like a 35-year-old person that's aging just as fast as an 85-year-old person ages, but the older person is the one they're exhibiting the cumulative results of aging. So organs and tissues organ and tissue aging can be accelerated by a variety of different factors, and some of that is good genes, right? Or bad genes, I guess, it depends. But it can be your genetic qualities, any pre-existing diseases or conditions, someone's overall diet, exposure to toxins and levels, and like their psychosocial characteristics as well. So did they put sunscreen on, or were they a sun lover and never put sunscreen on? They'll show more signs of aging in their skin and that type of thing. The aging rate does really vary from person to person. Just like I said, the genetic factors, the different conditions, no 2 people lead the exact same life or have the exact same DNA, with the exception of, maybe a set of identical twins at some point. But it's normal for aging to have a decrease in that functional capacity, especially respiratory. When you talk about respiratory capacity, it undergoes a huge reduction with age, as well as the vital capacity. And the residual volume, or the amount of air left in the system that isn't being exchanged, but is in the system, that actually increases. Um, and then the changes in blood flow distribution in the lungs results in declining oxygen saturations as well, or partial pressure of oxygen dissolved in your blood. Trying to see, trying to get it to switch. It doesn't like, there we go. So there are changes in the respiratory system again. We talked about that overall decrease in like the usable space and decrease in the oxygen saturations, but we also see the decreased sensitivity for and the overall CNS, like the central nervous system response to that's ABG is our arterial blood gas changes. So our like acid base buffer and whatnot, that's those receptors, baroreceptors and chemoreceptors, those type of things, those changes that would normally have us affect and have a more of a compensate with our respiratory mechanisms, we have a decreased sensitivity, so we have a harder time compensating. Sometimes there's limited chest expansion anatomically that way, as well as just knowing that defense mechanisms are kind of less effective in that aspect as well. Changes in their skeletal structure, like if they have kyphosis or like anything like that. Kyphosis is the like hunching over when they get like hunched backed. That decreases the ability for the chest to expand and decreases that muscle strength as well, and might require more energy for overall breathing mechanism. Some changes in the cardiovascular system. As the heart gets older, it's decreased efficiency. The vessel walls thicken, as well as the amount of elasticity in the vessels decreases. And that's why we don't see a huge response, that's why we see a bigger response or bigger changes, because they don't have that elasticity to help. In that same term, if you think about the walls of the ventricles or the walls of the heart, you might also see some thickening of those walls, which can lead to more rigidity. Ooh, that's a hard one. And then you might see other things that add to that systolic hypertension and diabetes, atherosclerosis, renal disease, like renal compromise, or starting having some kidney disease. So you might see some changes that way because you can't get rid of fluid as effectively, so you have an increase in your systolic blood pressure. There's also, again, we're going to see that collagen and elastin production, that flexibility, elasticity changes or decreases with age as well. The heart's electrical conduction system undergoes changes over time. So the number of pacemaker cells decrease with age. So if the pacemaker cells are decreasing with age, then we do have the potential that bradycardia can occur. Can't move that. I just changed the slide. Okay, bradycardia can occur, especially if those conduction systems start to slow down or are less effective. So keeping those things in mind. Some changes in the nervous system. We're going to see a decrease in the brain weight and volume that reflects the overall aging process. So the human brain has reserve capacity, so a smaller and lighter brain doesn't necessarily interfere with the mental capabilities, but overall there will be that volume decrease. There might be some mental decline, and as the mental functions start to decline, that's when we start to see decreases in some of our physiological processes like our respiratory rate and depth, pulse rate, blood pressure, hunger and thirst. Overall reflexes become duller. The regulation of temperature is a lot harder. So our geriatric patients are going to be more likely to, let's see, they're more likely to get burned or have a more severe burn because their reflexes aren't as sharp. So if they touch a really hot pan, where we would be like, oh, that's hot, and let go really fast, they have the potential where they may touch it and then the reflexes are slower, so they hold on longer, which means they burn more. Decline in the ability to regulate temperature can be an issue. More specifically, extreme temperatures and exposure, so they're more susceptible to exposure outside, and whether that's hot exposure where their body can't cool down, can't sweat enough, or if it's cold exposure where they're thinner skinned, and not, they might not have as much fat deposits to keep them warm, so they can become a lot colder faster as well. They're also less likely to recognize these exposures because their nervous system has declined, the function of the nervous system's declined more, so they might have they might have a harder time recognizing those changes. And that's where sensory changes come in. Those sensory organs decline with age as well. So you don't want to assume any patient's blind or deaf. You don't want to start off by like, hi, how are you? Because that's insulting, right? But if they're having trouble hearing you, then you can increase. Vision changes are something that we see as people age. If they have vision issues, it usually gets worse with time. They have more difficulty seeing at night. They have a harder time recognizing rapid changes. And when that happens, we all know the stereotype that old people don't drive very well. Part of that is because they have slower reflexes. They have slower reflexes. They have harder time seeing things with their vision. They have the inability or the inefficiency, or they have problems adjusting to rapid changes. And then overall, they might also not hear the horn that's honking at them. So there's a bunch of things that can affect it, or that it can affect. Gradual hearing loss is also something that's common. And that can be from just regular aging. And then also, if you think the likelihood of somebody at the age of 65 being exposed to extremely loud noises in the last 65 years is probably a lot more than someone in the age of 5. Someone at the age of 5 probably hasn't been around extremely loud noises or high decibels to damage their ears either. Hearing aids are definitely a common assistance device for the elderly. They fit right in the ear canal. They're usually battery operated, and they're very expensive. So old people will freak out a little bit if you're like, oh, take that hearing aid out, and you're not like guarding it like it's a bar of gold, essentially. As technology increases, we are now having hearing aids that can be controlled on like an app on the phone. There's also hearing aids that can Bluetooth to things. My grandma just got $10,000 hearing aids, I think like in the last year, and her hearing aids, she can Bluetooth right to the TV so that she doesn't have to have the volume at max like she did before, and she's not bothering everybody else, and she can hear it directly. We do have some issues getting her attention when she's watching TV, but that's better than not. Oh, and hers, some of the hearing aids now, you can, instead of having like a little battery in them that you have to replace, they come rechargeable. So at night when you take them out, when you go to sleep, you plug them right into like a docking base, just like you would your phone or your iPad or, I don't know, anything, and you dock it, you plug them right in, and it charges overnight. Other sensory changes. So another disease that we will talk about is going to be, sorry, getting blinded by the sun, is Meniere's disease, and it's a hearing-related impairment, and that is actually the onset's in middle age, and the symptoms present in the in like a cyclic fashion, and it can last several months, and it can definitely cause some troubles or cause some irritation to the person that's experiencing it. So vertigo, hearing loss, or tinnitus, where either they can't hear anything or they just hear a ringing. They can feel like there's pressure in the ear, those kind of things. Changes may make it difficult to produce speech that is loud enough, clear, and well spaced. So make sure that you're taking that into account. You try to face them. You ask them which ear works. I've had it where one guy's like, this ear is deaf, so talk into this one. And he it's like, talk right here. Those kind of things. Some other changes as they get older is their proprioception, so their sense of body position. Proprioception might be impaired or decreased. They might have changes in appetite. They might have a decrease in their sense of smell or taste. Taste is actually a big one. If you notice, old people tend to salt their food more. Because as they age, their taste buds become less too, and then they have to, and then in order for them to feel like the food tastes good, they add more salt because the sodium chloride activates the cells and sends signals. Changes in the digestive system, as well as changes in taste. Again, they have fewer taste buds. They tend to have more dry mouth, so the reduction of saliva. Dental loss, they might have, their teeth came in, at between the ages of 5 and 10 or 15, I don't remember now. But they might have, trauma where they lost teeth or they didn't take good care of them or whatever the issue. They might have some denture stuff. Dentures themselves not pose an issue, but can cause a risk of choking, heartburn, abdominal pain. Any of those things can be some issues that way. Slight changes in the digestive system also include changes in the size of the large and small intestine and their functions. The rectal sphincter decreases in size and strength, which can cause some incontinence issues. If it's not strong enough to keep that door closed, that you might have some unintentional escapes. Also, some things that worsen constipation can be some specific medications that they might take, their diet changes, or if they're not getting enough water, decreased physical activity. I don't know if you guys have ever made the connection, but the more active you are, it will help get things moving as well. And when they have this decrease, they're already facing constipation issues. They can have some more straining bowel movements, which can lead them to have some issues associated with like hemorrhoids. There we go. Gastric secretions are reduced. Overall, it's a reduction in everything. A reduction in the ability to secrete things, in the ability to recognize the signals your brain's telling you that you don't get as many signals that you're thirsty or that you're hungry or you have to go, and then overall your body's kind of just failing on you. Liver enzyme changes there's some decline there, and then there's others that do increase, but the enzyme system that detoxifies starts to decline, so they have a lesser ability to break down certain toxins, so it takes longer to break down those toxins, and then they're more likely to be taking more medications because of their failing health and failing issues. So it might be a combination of the enzyme enzyme system, as well as the addition of multiple medications or multiple things for the body. Even though the medications are there to do a specific function, it's still something that the liver has to process. So that can cause a reduction as well. Kidneys and your renal system tends to decline with age. It has a harder time maintaining the fluid and electrolyte balance. So aging kidneys, especially, can lead to more severe dehydration if if the electrolyte balance isn't right. Because if you think to the loop of Henle, and we think about that when the salts are pulling waters in and out, we're trying to balance those electrolytes. We need those there because they're the ones that pull the water out. But if we're too salty or we have we're pulling too much water off, then we can be drinking a gallon of water a day. But if we're peeing out more than a gallon of water a day, it's gonna lead to dehydration. It also can lead to overhydration, especially that's why that older people tend to, or the ones that have health issues can sometimes be more, is that sodium free or low sodium for those kind of things? It can lead to like high levels of potassium and different issues, and can become overall over changes to the endocrine system. The biggest one that we really talk about is as you age, your ability to make insulin or produce insulin and metabolize glucose decreases. And so the CDC says that it's estimated about 27% of geriatric Americans or US residents, whatever, are suspected to have diabetes. And they have a greater risk of getting diabetes just by a lot of the comorbidities that can be related to aging. And then as well as medications can affect their glucose metabolism. And so it's an issue that a lot of geriatric patients may be facing. We also want to look at or take into account the increase in the ADH hormone, or ADH, or antidiuretic hormone, which can also lead to more electrolyte and fluid imbalances, and can the increase in antidiuretic hormone is that increase of holding fluid in, or the inability to let that fluid out. So we might see pedal or other peripheral edema. So your hands, your feet start to get puffy. And then luckily, or unluckily for me, I suppose, menopause can also, which not happening to me right now, but when women hit menopause, they have a decrease in their hormone secretion, especially estrogen. So they can have some issues associated with that decrease in estrogen, which can mostly affects their down there, I guess is the best way to put it, but it can also affect some of their mood imbalances as well. It won't skip slides. Why can't I get it to move to the next slide? All right. I can't get it to move to the next slide. Hold on. Okay, trying it again. I don't understand. Oh. All right, I figured out the issue. We're back. Okay, so other changes in that we might see could be in the immune system, and as we age, we will see that our immune system isn't as effective as it was. They're more prone to infection, as well as more secondary characteristics, or excuse me, secondary complications from infection. And those chronic conditions that place people at a greater risk of getting a serious infection include diabetes, dementia, malnutrition, and some cardiovascular diseases as well. Infections do tend to manifest a little differently in older people than they do in maybe someone my age, or like a not regular adults, but younger adults and kids. So a fever usually indicates a severe infection. If they have if they have like a younger infection or one that's not as severe at that point, they might not have a fever at all. Not all older people with severe infection have a fever because of the aging immune system's inability to initiate that fever too, and regulate that body temperature. I think the easiest one for us to see in geriatric patients are the changes in the integumentary system, or the changes in the skin. As we get older, we get wrinkles, we get the more like slack skin. The resiliency is really lost. The wrinkling is caused by the skin becoming thinner, drier, it's less elastic, and it's overall more fragile. And as that sub-Q fat becomes thinner, bruising is a lot more common as well. Our skin's ability to, get a cut or tear, or I'm trying to think of a great example, like instead of it just doing like an abrasion, older people have less elastin and collagen. So instead of it being just an abrasion where I have like a scuff mark on my shoulder because I ran into the wall, they're more likely to have whole skin tears where it rips off. If you have never seen a skin tear, highly recommend Googling skin tear and seeing it. Literally looks like a whole section, a whole clump of skin is just torn off. Which can lead to more bleeding, because more bleeding occurs before homeostasis takes over due to the loss of that overall elasticity, that ability for the skin to kind of pull together and contract and try to close that site that's broken. Skin is also more prone to tenting, so when you're checking like skin turgor, even if there's no dehydration, they're more likely you go in, like you press a finger in, and it more likely is to stayed tented like that, even if there's no dehydration, just because the elasticity is gone. The sebaceous glands produce less oil, so the skin tends to be drier overall. We see, issues with, if you think about an old man, and yes, it is, balding is not just for men, it can be a trait of females as well, but there is obviously a direct correlation and causation, because as we age, we tend to lose more hair. Let's see. Some of the other things that is the overall, this changes, you can get little purple patches on the skin. I don't know if you've ever seen that, or like like age spots. That is because the production of new skin takes longer. So if there's any kind of injury or infection or scratch or anything like that, it takes longer for the new skin to develop because of aging. Okay, so when we talk about homeostasis, we're going to talk about the ability of the body to maintain a constant balance. And so we see, like, to use a thirst mechanism as an example, as we age, we tend to have a decrease in that thirst mechanism. It becomes more depressed. And so older adults are more likely to become dehydrated because they don't have that little, warning light going off in their head saying, hey, you're thirsty, you're thirsty. So that's an example. Temperature regulating mechanism. Overall, our body, our body's ability to regulate our temperature, it becomes harder. Um, it's more vulnerable to those environmental stressors, even after minor exposures to heat or cold. And then like blood glucose regulatory systems, we talked about that a couple slides back in diabetes, but we see it become impaired because of the aging process as well. Some changes in the musculoskeletal system. Overall, there's a decrease in bone mass in both men and women. Bones become more brittle, they're easier to break. There's less mobility and flexibility at the joints because tendons and ligaments lose their elasticity, or there's been previous injuries. The synovial fluid, or the fluid in between those joints, tends to become thicker, which makes the joints a little creaky, or your joints are stiff. Well, that's true. It's like think about thick oil in a car. New oil is way better than the thick old clumpy, lumpy, chunky oil, or whatever you want to call it. Overall, when our geriatric patients are more susceptible to fractures from falls because of possibly osteoporosis, or because they have their ability to regenerate or heal from an injury is decreased, as well as falls are more likely to happen because as we age, the proprioception, or their place in the universe, or place, their space in their environment, decreases, so their balance gets worse. Posture changes, height decreases as the spine gets compressed over years and years of being upright and the pressure on it. And then overall muscle mass and strength starts to decrease because, again, as we age, our cells regenerate at a slower rate, or if you're not as active, you also can lose that muscle mass just from muscle atrophy, which all of these things can make any tasks that a geriatric patient might have to do harder, and they have more difficulty with it because they lack that fine motor coordination, muscle strength, finger strength, all of those things, and overall leads to a slower lifestyle. All right, so we're going to talk about more patient assessment, and I did knock a lot of stuff out of this because if it's not any different from your normal assessment, I'm not even going to bring it up. I'm trying to keep this as short as I possibly can. So when you're looking at a geriatric patient, it's one of those things. Like, again, illness is not inevitable with aging, meaning complaints from geriatric patients shouldn't be ascribed to getting old. Aging is a continuous and normal development, development sequence. The biological effects of aging are from normal wear and tear and also the genetic makeup. So there is this widespread misconception that older adults are hypochondriacs, or that they're, being dramatic, but older patients tend not to complain even with real symptoms. If an older person calls for pre-hospital care, there's usually a real problem. Now, that doesn't mean always, but it does mean that they also know that they're at that stage too. Some signs and symptoms that are altered from aging. I think that one of the bigger ones is that MIs, or heart attacks, may not include chest pain. These are going to be your indigestions, your chest pressure, I just don't feel right, or I feel really weak. Another change that throws people off is that pneumonia may not include a fever. So you might have a patient that's coughing things up and, has gunky lung sounds and feels like crap, but they are normothermic, which would throw us off. But as we get older, that's normal. Some other signs and symptoms that are different from aging is going to be, or could be, that uncontrolled diabetes is more likely to present as HONC or HHNS, or basically non-ketotic, like hyperglycemia. And one of the other bigger things is that some conditions that normally wouldn't affect a younger adult's mental status could make an older adult appear to be in delirium or delirious. When we're going to do an assessment on a geriatric patient, you really want to get a good health history, as you would any patient, but it's specifically important in the elderly population. A lot of their conditions, hypertension, stroke, diabetes, cancer, that kind of stuff is all things we want to include in the health history. But there also might be multiple pathological conditions. So symptoms of one disease may hide or alter symptoms of another. It's just kind of, it's like that polypathology, just like when we think of someone taking multiple medications, we have to look at it from a polypharmacy, that, some things might mask other things or cause other problems or issues. And then keep in mind that disturbances in one body system might cause a domino effect and start causing problems in multiple systems. And it can be kind of hard sometimes to figure out which came first, the chicken or the egg. Like, which one of these symptoms or which one of these conditions is causing these symptoms? And sometimes that's hard to prove. There's more contraindications for elderly or those that are on a lot of medications. And the elderly also, or the geriatric patient, might also have that decline in their liver's ability to process medications. So they may need some dosage modifications from a regular adult, because they aren't able to process those medications as effectively or as fast as a normal adult, so they might need a lower dose. When you're using you can use this mnemonic, the GEMS diamond, right? The GEMS diamond instead of the pediatric triangle. The GEMS diamond forms a good general impression. You're going to look, is it a geriatric patient? Do a good environmental assessment. What's going on around them? Do they have good family support, or that's more of a social assessment? You want to look at their medical assessment, look at what history they have, what meds they're on, and then a social assessment is what kind of activities are they doing, what kind of social and family support that they have, that kind of stuff. You can use GEMS to figure out a good general impression. It's definitely not taken hold like the pediatric assessment triangle has, though. When you are going to take a history of a geriatric patient, make sure you include pertinent medical history, their current cardiovascular health. Okay, they had a heart attack 20 years ago when they were 50, but now they're 70 and their heart's doing really, really great. How well they can normally get around, their exercise tolerance, how they're eating. You can kind of get a look and see what their diet history looks like, what medications they're taking. Just because someone says they're a non-smoker at the age of 70 doesn't mean they didn't smoke for 30, 40 years before that. So getting a history of their smoking and drinking habits as well. And one thing to remember is that the chief complaint might be difficult because the patient might believe that the symptoms they're experiencing are just part of getting old, or they ignore some of those more legitimate symptoms because they don't want to look like they're hypochondriac, or they might report more vague symptoms. So determining that chief complaint is a little bit more difficult, but that's why I think I've told you guys before, I like to ask the question of, hey, is there anything that's new or different that you might not think is totally related, but is there anything else you've been experiencing lately that has been bothering you or that you've noticed? That's one of my favorite questions to ask during a history, just because that's when you tend to find some of that stuff that is a real problem, but they didn't want to look like they were complaining too much. You also want to take into consideration that if they have a chief complaint that seems really trivial, ask some other questions, screen through their questions, especially if they're like, man, my toe hurts. And you're like, okay, again, that's really trivial, but ask other questions. Have you hurt it? Have you tripped on, or like, have you dropped something on it? Has it experienced any trauma? Like you could do, there's so many more follow-up questions to that. Well, your toe hurts now, like, you know, what's different about that? Why is that something that you could decide to call on us today rather than yesterday? Especially if it is non-traumatic. So ask, like, okay, you have a headache. Have you had a headache before? Well, yeah, I've had a headache for the last month. Okay, well, why did you decide today to call us instead of last week or 2 weeks ago or the first day you had the headache? What changed? And that's when you might get some additional information that makes it more sense or that sheds light on it. Let's see. Yeah, how does this differ from last week? What happened today to make you call? What's different? And then from there you can move on to getting a detailed history of medications. That's going to be pretty important as well. And noting any medications that they're prescribed, but they're not taking. It's going to be a big deal if they're not taking their blood thinning medication and they have a history of AFib and clots. That kind of stuff as well. Depending on your system, you want to make sure if you're going to take medications to the hospital, which is something that they used to encourage everybody to do, is to take their medications to the hospital. Just make sure you get permission, you don't just snatch them. Or if you have a good medication list, that's super helpful too. Especially if you think someone has a higher likelihood of getting admitted to the hospital for multiple days, you might want to ask them if there's any medications that they want to bring with them that they need to have. Obviously, the hospital is going to have, metoprolol and Protonix and, all of the medications that we probably know the name of. But I can give you an example is that when I was inpatient just in March, the hospital didn't have Rinvoq, which is my new medication that I'm on now, didn't have Rinvoq in their pharmacy. It's a new medication, it's super expensive. And they just don't carry it. They don't keep it on hand. And so in order for them to get it to me, they had to order it and have it delivered and had it just like a pharmacy would. And it didn't even go through actually the hospital. It actually went through my doctor's office. So that's something to take into account too. The hospital might not have access or might not have the supplies for all the meds. When we're doing a secondary assessment on a geriatric patient, older people are more likely to have orthostatic changes in their blood pressure, or postural changes in their blood pressure from where they go from, there's a marked difference with, possible hypovolemia or over medication. Overall, geriatric patients' blood pressures tend to average higher than that of younger adults, just because they have the less elasticity in their vessels, and so it tends to be higher because it can't absorb that shock and that pressure from the ventricle, from the heart's pumping out blood, for Pete's sake. You don't have to change what you do for your assessments. You're just going to be a little bit more aware of adjusting the needs of your patient assessment to them being older. You obviously don't want to, turn their arm and kink it out all in weird angles like you would maybe a 7-year-old that had like a scrape or something, or even a 30-year-old. They should be able to, normal one should be able to, move or manipulate, whereas the older they get, the less likely they are to be able to move like that. Older people do tend to be more prone to hypothermia, so they tend to want to be warmer. They feel colder faster, or they don't feel the changes as well as a younger adult might be, and they also don't have that reserve fat capacity, so they tend to feel colder as well. For these older adults or these geriatric patients, if we take off any clothing, we want to make sure that we recover them immediately or pretty quickly, and we want to do that not only to keep them warm, but also to kind of preserve their dignity and whatnot. Next, we're going to talk about some management changes in respiratory conditions. First one we're going to talk about is pneumonia. We know what pneumonia is. Again, we've talked about it several times. We just went over it in peds, so I'm not going to talk a ton about that. But I will highlight that it has the biggest impact on older adults. Some of the risks include any other underlying health issues, anybody with a depressed immune system, and those who are generally immobile, confined to bed, those types of things, because the more when you're exercising and you're using your respiratory system to its fuller capacity, you're able to expel, and you're breathing, that movement, you're able to get any bacteria or viruses that implant into your respiratory system. You're more likely to be able to get it out or reject it. On the same note too, because you're moving that air more. So those that are intubated, that have a defined set, when you have somebody on a ventilator, you set the volume of air that you want moved in and out, and so you have it set to 500 cubic centimeters of air go in and out, right? Well, if they have a capacity of 650, there's 150 cc's of air that just doesn't move every time. And it's harder to get that, especially if you're still laying in bed, right? You don't get out of breath just laying in bed because, well, you can, but you don't do that because you're not moving the air. You're not doing your respiratory rate slower. You're not needing your oxygen. Your overall oxygen demand is lower. So that can impact it as well. Some of the symptoms of pneumonia in older patients that don't present as much in the younger patients are going to be that delirium, or that really acute confusion. It's more likely to happen in an older patient. They're not going to have that fever like we talked about earlier. They might not have a cough at all either. They might show more signs of wheezing or abdominal pain, or even rhonchi in those affected lobes. Treatment for us, or treatment for the patients pre-hospital, is going to be, we're going to get fluids, we're going to give them oxygen if they need it, and if your protocols allow it, you can give an analgesic for fever, so antipyretic, not an analgesic. You'll give an antipyretic for the fever. That's a typo. There are vaccines for pneumonia, and the other ways to prevent pneumonia is going to be quitting smoking and doing those respiratory exercises. Have you guys seen? It's called like a spirophygmometer or something, but it's a little. God, this is going to sound terrible. The little like device that you blow into, or you can blow or inhale, or usually you blow into it, and it moves the little ball in the tube up, and it can show you how much pressure, your ability to move that ball. And especially after you've been intubated, they have you do that. Pneumonia patients, respiratory patients. It's practicing exercising those respiratory muscles and getting that air moving. Another disease that we see more likely is going to be COPD, or the chronic obstructive pulmonary disease. And those diseases are chronic bronchitis, emphysema, and asthma. Those are the set of diseases that we'll talk about. It's not different from anything that we learned in ME1. And we know from ME1, it's sometimes difficult to distinguish between these diseases. They have overlapping characteristics. And as people age, overall the lungs' elastic tissue decreases the ability to fight infection, and it decreases the ability to get rid of that inflammation in the airways. That the chronic obstructive pulmonary diseases are characterized by that inflammation of the airways, so it's harder to get rid of it. Again, preventative measures for this is going to be quitting smoking. Obviously, don't get exposed to like pollutants in the environment or like irritants in the environment. Get your immunizations to reduce any infection, any other issues that can cause cause an issue simultaneously and make one thing worse. And a lot of them also chronically take an inhaled oral steroid. Treatment for us pre-hospital is going to be give them oxygen if they need it. If they might require a bronchodilator, so you can consider giving like albuterol. That's our beta-2 agonist, or you might even need to put them on CPAP, that continuous positive pressure. Asthma is something that can occur or present in old age. It's usually accompanied with some of the other diseases as well, but it manifests with that shortness of breath, a chronic or night coughing, and then wheezing. And again, the way we manage asthma is going to be the same as how we would manage anybody else that was having an asthma attack, with the exception of being cautious in using albuterol or another beta adrenergic agent, because it can make some cardiac symptoms worse if it's an issue. If they have heart problems, we want to be careful with it, because giving albuterol can make the heart rate increase, which can then cause other cardiac issues. So, we see the last respiratory condition that we're going to talk about for geriatrics is going to be the pulmonary embolism. We know that a pulmonary embolism is when a blood vessel supply in the lungs becomes blocked by a clot. And that can cause irreversible damage or infarction to the lungs. An embolus is released typically from a damaged heart or a vein in the lower extremities, pelvis or abdomen, and but it's most commonly caused by deep vein thromboses or DVTs. Prevention is based on the risk level of the patient. They're at a higher risk if they've been a surgical patient's at a higher risk for a potential embolism. So if a lot of times when they do some of those major surgeries, they will give people Lovenox, is usually the anticoagulant of choice for the hospital setting. They might do compression socks. They might, I don't know if you guys have seen the little like air like it looks like blood pressure cuffs for your legs, but they wrap like your legs in cuffs, and then they'll inflate with air, so it like squeezes and helps push the blood up so that it doesn't become stagnant or start to coagulate. If we do have a geriatric patient that is showing signs that they might have a PE, pre-hospital treatment is going to be still the same, ensuring airway and ventilation. Yeah, do as much as you can. ABCs, ABCs, ABCs. Get lots of vascular access and let the hospital know if it's something you suspect. They're more likely to get a PE, especially if they have a history of cancer, previous heart attack, or cardiac dysrhythmia like AFib, or if they have any other clotting disorders. So ACS is probably the most common cardiac issue, like acute coronary syndrome, obviously. But some of the things in older adults where it might be different from someone at the age of, say, 40, excuse me, is that pain isn't the presenting factor, usually, in older patients with ACS. They might complain more of difficulty breathing or passing out, or nausea, the more like kind of vague overarching symptoms. You really want to maintain a high index of suspicion for acute coronary syndrome in older patients who may have had any complaints between their waist and their nose, which that really doesn't narrow it down at all. But what we want to do and what we will do is a prompt 12 lead. It's a lot of the times you're going to do a lot of 12 leads in that older population. Older geriatric patients tend to have heart failure. People 65 years and older are a high risk group for congestive heart failure. Some of the risk factors include things that you see up there. And again, prevention of getting heart failure is staying healthy, stop smoking, eat a healthy diet, make sure your blood glucose levels aren't crazy high or crazy low, exercise regularly or move your body regularly, which if you do the things before this can help control your weight. And then another really big one for heart failure is that hypertension control. So making sure that you're not hypertensive for long periods of time. And that's why there's a difference between our ambulance patient being hypertensive. We don't think of 140 over 80 or 140 over 90 as being like significantly hypertensive. Being 140 over 90 isn't going to do immediate damage. However, if you lived the decade of your 40s with chronic hypertension at 140 over 90 or 150 over 90 or 150 over 80, any of that stuff, even if it's lower scale, having that increased hypertension for long periods of time can lead to heart failure. Those muscles get thicker because they have to do more work, so the thicker those muscles get, the less elastic the heart gets, and the bigger the muscles get, the less space in the heart for blood to be, and it lowers your ejection fraction. Acute exacerbation of heart failure, or CHF, can present with pulmonary edema, or difficulty breathing the fluid built back up into the lungs. And mental status changes can also occur because of that decreased oxygenation to all the organ systems. They might have that sensation or that feeling of air hunger. So there's definitely a feeling of, I'm having difficulty breathing and I'm short of breath. Even though a lot of times we use those two terms interchangeably, if I have a patient that is having breathing issues, I'm going to ask that question of, Do you feel like you're having a hard time getting the air in? Like when you're breathing in, do you feel like it's trouble getting in? Like you have to use a lot of muscles to get it in? Or are you feeling that's more difficulty breathing? Whereas they might not have any difficulty breathing. I can breathe in and out, but even though I'm breathing in and out really well, I'm short of breath because I'm not getting the oxygen, I'm not getting that gas exchange. So there is a difference in those questions. Let's see. Heart failure, yeah. Basically for that, we just really want to make sure that we're asking about those signs and symptoms, looking for that peripheral edema, which is can indicate that there's a worsening of the heart failure as well. And then just making sure that in like the absence of any other symptoms, that the pulmonary, or excuse me, that peripheral edema can be indicative of another circulatory or integumentary problem. So, or even an infectious disease problem. So if they have peripheral edema, but they don't have CHF or they don't have any other symptoms, it might be something else. Let's see. And it's also important to note that if your patient is bedbound, they might not have pedal edema because their legs are never the lowest point of their body. They might actually have sacral edema, or like their butt might be edema. Their butt, lower part of their body there, where the lowest point is, the fluid sets in there. Let's see. Acute exacerbation of heart failure or CHF is often linked to, these type of issues. However, it can be also environmental conditions as well plays a part. So the hot, humid days, the humidity tends to exacerbate CHF as well. And if we get to one of these patients that is having CHF or heart failure, our pre-hospital treatment is no different than that of any other population. The biggest thing is that you need to become familiar with the medications that the patient's taking and why they're taking them. And evaluation of the end tidal should be done immediately and monitored throughout transport. Their end tidal capnography is going to be a great tool for you to see how their ventilations are going, how their body's reacting, and it also will tell you if you notice that they're breathing really fast, but their end tidal is really high, that is a mismatch, right? If they're breathing really fast, their end tidal should be lower. But if it's not, then you know that there's probably something else going on, and it can be indicative of something else going on. These patients we should be careful about how much fluid we give them, and be careful of that stuff overall. We don't want to do fluid overload. Cardiac dysrhythmias in older populations are usually the result of just those changes that come with age. Those heart cells aren't able to regenerate as fast. They might have other cardiac conditions that affect it. They might have some adverse drug effects or drug reactions could cause a dysrhythmia, or it's a combination of factors and you don't really know why. AFib overall increases the risk of stroke and heart failure because of the blood is allowed to become static. So that blood stasis allows some coagulation and clot formation, but eventually it's more than likely going to get pushed out, and then that clot can enter either the pulmonary circulation, depending on if it's coming from the right side, or it can end up even going to the brain to cause a stroke because it's coming out of the left side of the heart. So it just depends on where that blood sat. Bradycardias are more common in older people. However, because of that aging conduction system we talked about a little while back. However, it's relatively benign. It can be relatively benign. They're more likely to have a lower heart rate because of that aging conduction system. But beta blockers or calcium channel blockers or dysrhythmic or anti-dysrhythmic medications that can tend to slow the heart rate down, as well as things like constipation or bearing down can cause bradycardia, in that same sense that they're more likely to pass out or lose consciousness that way because of they might vagal out that way. Hypertension, when we're talking about cardiac issues, about 70% of adults older than 65 have hypertension. Most have isolated systolic hypertension, usually from the arterial from like the arterial elasticity loss. So like they have hypertension because those vessels don't have as much elasticity in them anymore, allowing for the pressure to not be quite as bad. But overall, trying to control systolic and or diastolic hypertension prevents stroke and MIs. When we take the workload off the heart that has to use less oxygen, it doesn't have to work as hard. Because of the hypertension, it can help prevent some other issues. There's some emergencies that required controlled blood pressure decline, but we're like basically administering beta blockers. However, we don't do that pre-hospital. That's one of the reasons why when we went through ACLS, I was like, forget anything you heard about any of the lulls. We don't use like sotalol, which is in AHA, in ACLS, AHA, that's one of your treatments. Is using sotalol or a beta blocker, but we don't want to do that. We don't use it pre-hospital because we don't ever want to lower their blood pressure unless we don't want to do that. We just want to get them to the hospital. We don't have anything really to decrease blood pressure other than nitro, and we do have, if we have a rapid onset of systolic hypertension, depending on your protocol system, you might have the ability to administer some nitro to temporarily relieve that hypertension. But that's generally not what we want to do because we know nitro's half-life is only about like 5 to 10 minutes. So it's not a long-term solution. It would be a temporary solution. So when we talk about aneurysms, again, I've talked about aneurysms before, and it's overall the weakening of an artery, and what happens then is like a little balloon. The weakening of the artery wall produces like the aneurysm essentially, and creates like the balloon defect. And while we've talked more like with kids, and we've talked more about in neurology, where it can be a congenital condition where they have like AV malformation, or they have there's other genetic conditions that cause aneurysms, like Marfan syndrome. I think I talked about that before. Marfan syndrome is where they're like the super tall giants. They have the long bones, or the super long bones. Yeah. That syndrome is also a characteristic of Marfan syndrome, is also having weaker arterial walls. They have it's a connective tissue disorder, so they have weaker arterial walls like you lead to, and they're more prone to aneurysms. Overall, some of the contributing factors to an aneurysm that are acquired is going to be something that usually presents more in older population. So chronic hypertension or atherosclerosis or obesity, all of those incidences increase with age. So if we have a patient we suspect is having an aneurysm, that would be, we want to try to recognize that as fast as we can, because if you're recognizing that they have an aneurysm, it means that the aneurysm is leaking or has already burst, because your aneurysm is asymptomatic until they become really large, they leak, or they rupture. If it's become just large and it hasn't ruptured yet, you might see symptoms with difficulty swallowing or hoarseness, some of those things, but otherwise it's depending on where the aneurysm is when it becomes symptomatic. Treatment of aneurysms are going to be definitive care, and it's going to be usually abdominal surgery if it's in like aortic aneurysm. However, if it's a brain aneurysm, it won't be abdominal surgery. They'll probably go through like your femoral vein and go up, or your femoral vein or artery and go up that way and try to repair it. So what we want to do, ABC, is supportive care and transport emergently if we suspect an aneurysm. There are different grades to aneurysms, and you can see these here, or sorry, not aneurysms. There are different grades to aneurysms. But when we talk about a traumatic aortic disruption, or an aortic dissection, it's when the inside artery wall tears and blood starts to collect between the arterial wall layers. And this can occur from trauma, or it can be from sustained or chronic hypertension, especially if there is an abdominal aortic aneurysm present. Overall, it just weakens the arterial wall and makes it prone to rupture. And let's see, thoracic dissection, or the dissection of the thoracic part of your aorta, can mimic cardiac ischemia, can mimic a heart attack. So the best things to do if you're suspecting that it could be a thoracic dissection, or a thoracic aortic aneurysm, is really just obtain the blood pressure readings in both arms if the patient has chest pain. If the pressure is different in one arm, drastically different from one arm to the other, that can be suggestive of a dissection. Specifically, the systolic blood pressure is different by 15 millimeters of mercury or higher, so 15 blood pressure points. Next, we're going to talk about stroke. Stroke is the leading cause of long-term disability, especially in our geriatric population. Overall, the risk factors, same that we've talked about before, that are listed here. Prevention, again, same as it has been, leading a healthier lifestyle, lowering your cholesterol, and improving your diet, being healthier. Over half of stroke survivors older than 65 experience a decrease in mobility. So if you've had a stroke, you're more likely to have another stroke, and that's one of the contributing factors to that. It is really important that we recognize a stroke early, and by recognizing it early, we can alert the facility that we're headed to so that they can get the stroke team ready. We transport them timely, and we want to use our like Cincinnati stroke scale or the LA stroke scale. You want to use one of those tools that you have to recognize it. We talked about trans-ischemic attacks, or TIAs, before as well, and this is going to mimic a stroke, except the difference in it is that it goes away. It goes away without intervention. Patients that have TIAs are at a much higher risk of having a stroke instead of another TIA. So we can see here in this picture, we have the healthy artery where it's flowing all good and well. And then we have the unhealthy artery that has that fatty plaque buildup and it's flowing. And so we can have a TIA if that vessel wall is, especially if that vessel wall constricts because of a medication, or we get really scared. Like, you can scare somebody into a heart attack or scare somebody actually into a stroke because they have that rush of adrenaline, and that rush of adrenaline or epinephrine in the system is what's going to make their vessels constrict so that we have that boost in blood pressure. It's also the same way why a boost in blood pressure can, there's not as much room, it can't move as well. The blood can't go through, it can get stuck. Also, it's why like my first ROS patient, I think I've mentioned this, my first ROS patient that I ever had was a guy that did a bunch of cocaine. Cocaine is a sympathomimetic, so it mimicked basically a dump of adrenaline or a dump of epinephrine into the system. His vessels constricted, and he was doing coke, so it's not like it's just going to go away. That vessel constriction caused a stroke. Or, well, in my guy, it actually caused a heart attack, but it could also cause a stroke as well. Anything with the vessel constriction, if there's a fatty plaque buildup or if there's any kind of issues like that. I am going to go ahead and publish this and upload this half of the slides just so that it takes so long, and hopefully this will upload. I'll have the next part 2 up here in a little bit.